you about some of those steps. But we finally reached the point where this trial should be starting next week. I'm keeping my fingers crossed. It might be the week after, but after about 1.5 years of preparation. So, and the trial is a trial for patients with their first treatment of Waldenstrom's macroglobulinemia anemia. And what I thought I would do today, this evening, is talk a little bit about how Waldenstrom's is treated first line. In other words, what is a little bit about Waldenstrom's in general, but across the world, how is the treatment of Waldenstrom's conducted at different locations? What are the standards of care, and how our trial has evolved from what we currently do to what I think will be an even better option for people down the road once we get the data in from this type of trial. And so I'm going to provide the rationale for this after reviewing some of the current background information on Waldenstrom. So I'm going to start off by showing my screen here, sharing my screen. Let's see. I should do it. I'm going to come over here. Now you should be seeing my entire screen here. Let's see, I want to do it, use slideshow. So that would be this one. Okay. So we're going to be focusing on the first line of treatment for Waldenstrom's macroglobulinemia. And I know many of you have a vested interest in this condition, either from yourselves or family members. So I know you'll be listening to this with great interest. So to start off with, Waldenstrom's, as you know, is not a very common type of lymphoma. In Canada, it's estimated that there may be about up to 8, 9, 10,000 new cases of lymphoma a year. And Waldenstrom's accounts for, I'm going to move something's in my way here. I'm trying to get my pointer, just bear with me while okay, there we go. Just going to move this so I can see this better. Yeah, so Waldenstrom's is this little thin wedge piece of the pie over here. It's about 1%. So you can imagine if there's 10,000, if there's 1,000 new cases of Waldenstrom's, if there's 10,000 new cases of lymphoma, there's about 100 new cases across Canada of Waldenstrom's each year. And so that's not a lot. And, you know, part of the strength of your organization is there's good communication, word of mouth, and a lot of support that's being passed on from patient to patient and family to family. And it could be a very effective way of spreading the word about trials where we really want to try to capture as many of those 100 new patients of Waldenstrom's, not all of whom, of course, will need treatment, but as we can, to be able to conduct this trial quickly and move on to and understand what it tells us. Just a minute, the next slide is over here. So Waldenstrom's, what is Waldenstrom's? Well, lymphomas are disorders of either B cells and T cells. Most lymphomas are disorders or malignancies of B cells. B cells, normal B cells, arise in the bone marrow as a committed lymphoid progenitor cell, and they go through a series of steps of differentiation where they acquire immunoglobulins or antibodies. They eventually migrate to lymph nodes where they go through further differentiation to eventually become mature plasma cells that are able to respond to antigens in the environment and secrete their antibody, which will then counteract or stop the growth or destroy the invading pathogen. Oh. And anywhere along this pathway where a B cell is developing, malignancies of these B cells can arise. And the type of malignancy depends upon the stage and the differentiation, where along this pathway the mutational events occur, and also the type of mutational event. So at the far end, we have myeloma and plasma cells, but very close to the final stages of differentiation, of a B cell, we have Waldenstrom's. And so it's a very mature B cell that can already secrete or produce an antibody molecule, the IgM molecule. And it's characterized by a very characteristic mutation, which is the MYD88 mutation. And talking about mutations associated with cancers, this is one of the strongest associations. 95% of patients with Waldenstrom's have this mutation. So this mutation in this type of a B cell, along with other mutations that also occur, because no single mutation is sufficient to cause a malignancy, but this driver mutation results in the mature B cell results in Waldenstrom's. So it's an uncommon, a very slow growing type of lymphoma. As I mentioned, it's associated with a characteristic genetic change, MYD88, and sometimes CXCR4 mutations. It's a mature B cell, and thus it makes this IgM paraprotein. And this is a very valuable feature of this lymphoma, because this is a very almost easy and effective way to monitor the status of the Waldenstrom's. How is it progressing? Is it improving? We can tell that very easily, almost from visit to visit, by looking at the IgM. We don't necessarily have to do scans or other invasive tests. The clinical presentations are those of any lymphoma, which can be lymph nodes enlarged, non-specific symptoms. Sometimes people get sweats or feel unwell and things like that, non-specific symptoms. But there are some unique symptoms that are a very special feature of Waldenstrom's. And so because of this antibody, the antibody can cause the serum, the blood, to get thick, and that can cause certain types of symptoms associated with neurologic findings, transient ischemic attacks, headaches, changes in the mental status. Cryoglobulinias, meaning that antibodies that can sort of precipitate in the cold and cause certain types of symptoms, and neuropathy. Sometimes the antibody can even react with the myelin or the covering of nerves and cause symptoms of neuropathy, numbness in the fingers and toes and other parts of the body. And there are many different treatment options for Waldenstrom's. One feature is none of them are curative. We cannot cure Waldenstrom's macroglobulinemia. In different parts of the world and at different time points, different types of treatments have been used, from chemotherapy drugs, proteasome inhibitors. These are drugs that are commonly used for myeloma, so they're effective in sort of more mature types of B cells, antibodies, Rituximab, BTK inhibitors, etc. And it's safe to say that at this point in time, we don't really know what the best first line treatment is, or even the best sequence of treatments. And different parts of the world use different treatments as their first line or second line treatment, different treatment algorithms. It remains to be determined what is the best treatment. And how do you define best treatment? Is best treatment the treatment that causes the longest remission, the deepest response, the least toxic, improvements in survival? It's a very difficult question, and it's sort of may differ from person to person, to physician in terms of what they value most in terms of a frontline therapy or a therapy for their Waldenstrom's. I thought I'd say a little bit about what can be expected in terms of outcome now. And this is important for a number of reasons. One is, usually when I see a patient in clinic with Waldenstrom's, they want to know as much about it as they can. They want to know, what's in store for them. And the first thing is that Waldenstrom's is a very heterogeneous condition. And what that means is that the expected outcome is quite different. It varies from short, relatively short for patients who have what we call a high risk prognostic score, to very favorable, very long. And these are median. And what this means, if you have a median survival of expectancy of 142 months, 12 years, that means 50% of people will live longer than 12 years. And so You know, it all depends on what this constellation of factors are, how many you have in terms of what risk category you will fall into. And this is important for the individual patient, of course, who wants to know what to expect, but it's also important in clinical trials. And it's something that we have to take into account, because when you're developing a new treatment or a new, in a new trial, you have to control to some extent, or you at least have to know what the composition of your treatment population is. Are they all high risk, in which case you expect different results, or are they all low risk? And so that's why these staging classifications have been developed to some extent to aid in ensuring that we have a good understanding of what the patient population is that goes into a clinical trial. I'm happy to take questions at any time. I don't see, I don't know how I would see you because I've actually taken off the, let me see if I can, but I think you'd have to, maybe Jack will be able to see the, or maybe, sorry, Paul will be able to see the, if there's any chat or anyone that wants to ask a question. And
if there's a question that comes up, I think is relevant to that moment, I'll interrupt you. Otherwise, we'll just keep going and save it till the end.
Okay, great. Okay, very good. So, so this is one staging system, and this is actually one of the original staging systems. This is what we call the revised staging and prognostic category. And this is a little different. This actually uses factors that are more commonly used in myeloma, but it does separate the patient populations a little bit more precisely into very favorable and a little bit more risk populations. So how do we treat Waldenstrom's now? What is the first line treatment? And again, I am focusing tonight on first line. At the end, if you wish, we can also talk a little bit about, you know, what are the options for recurrent Waldenstrom's, but that's not the focus of this discussion now, because the trial that I'm going to propose is in first line Waldenstrom. So this is the NCCN treatment recommendation. So this is the National Comprehensive Cancer Network. This is an American organization where experts from around the world actually get together, and they review the literature, and they create recommendations for most types of cancers, and, you know, from breast cancer to lung cancer to Waldenstrom's. And in these guidelines, they do review the literature, and they're not that didactic. They describe regimens as preferred regimens or acceptable regimens or recommended regimens. And you can see here that the preferred first line regimen, based upon the literature that we have, and this was created in 2019, are these chemotherapy combinations: bendamustine and rituximab, Bortezume, Dexamethasone, Rituximab, this is used in some parts of the world, and rituximab, cyclophosphamide, and dexamethasone. These are considered the preferred first-line regimens for patients requiring treatment, symptomatic patients requiring treatment with Waldenstrom's macroglobulinemia. But there are other regimens that can be used, and they're shown here. A number of different chemotherapy drugs can be used. Most of these are used in other types of malignancies or myeloma. Carfilzomib is a myeloma drug. Ibrutinib makes its way into another recommended regimen, although according to these guidelines, it's not a preferred regimen. So what I'm going to do is the regimen that we commonly use currently in Ontario, and I'd say in most parts of Canada, many parts of Canada, as a first-line regimen is bendamustine rituximab. So what I'm going to do is going to review some of the data on why, if you come to the Odette Cancer Center, would you currently, outside of a clinical trial, get bendamustine and rituximab as your first-line regimen for Waldenstrom's macroglobulinemia. And it's based upon this study. This is part of a larger study of this combination, bendamustine rituximab. It's called the STILL trial by Matthias Rummel and a European group. And it compared the chemotherapy bendamustine and rituxan to Rituxan and CHOP. And CHOP is a chemotherapy combination that's commonly used for more aggressive chemotherapies. It's quite a strong combination, I'd say. And we consider it a potentially curative combination for the more aggressive type of lymphomas. half of the patients with diffuse large B-cell lymphoma who received this R-CHOP will be cured. So this trial compared BR to R-CHOP, and BR came out ahead, considerably ahead. This is not a small difference. This is quite a dramatic difference in terms of the median progression-free survival. It was 70 months versus 28 months. So if you are a patient with Waldenstrom's requiring your first-line treatment for Waldenstrom's macroglobulinemia with bendamustine and Rituxan, you can expect a response that on average, a median will last about 70 months. Now, when you look at these types of curves, what that means is that 50% of patients will relapse and progress. Each one of these steps down here means someone is progressing, but there are many who progress much later. So that's a number to put in the back of your mind. And in fact, we'll be coming back to these numbers in a minute where I show you the results of another combination, which we want to compare to this 69.5. Now, not only was this better in terms of the progression response, progression-free survival, but when you looked at the toxicity profile, so these are the toxicities, bendamustine and Rituxan, comparing it to R-CHOP, they looked at different toxicities. So alopecia, no one lost their hair with bendamustine and Rituxan. The incidence of paresthesia, as numbness in your fingertips, was 29% with R-CHOP versus only 7% in bendamustine and Rituxan. So a few people got sore mouth, but it was greater with the R-CHOP. So many, and the sepsis was, again, the likelihood of developing a fever or infection during your treatment was less with the bendamustine and Rituxan with the R-CHOP. And all these numbers are pretty significant. When you look at the cytopenias also, there were fewer cases of leukocytopenia, neutropenia with bendamustine and Rituxan. So not only was it a combination that resulted in longer response, it also had a more favorable safety profile. Now, another major combination that's used is this combination here, which is Bortezume, Dexamethasone, and Rituximab. This is, again, or Velcade, Bortezume. This is a myeloma, so a drug that's very effective in plasma cell disorders, and this is a lymphoplasmacytic disorder. When you look at the progression-free survival, again, of these first-line patients, so a very similar patient population, and I didn't compare the exact details of their prognostic profile, but it was a very similar patient population. You see the PFS here is approximately 45 months. This is compared to the 70 months that we saw with the bendamustine and Rituxan. So this does not seem to be quite as an effective or as strong of a combination as the bendamustine and Rituxan. And that's one of the reasons why bendamustine and Rituxan is a preferred regimen. So now we move on to targeted therapies. And I know that all of you have heard about Ibrutinib and BTK inhibitors. What are BTK inhibitors? Well, this is a diagram that explains how these work. This is the cell membrane of a B cell. This is outside the cell. This is inside the cell. B cells and Waldenstrom cells express antibodies on their surface. And in a normal B cell, the purpose of the antibody is to detect some sort of antigen, some pathogen in the environment, and to send a signal into the B cell to become activated. And this goes through a number of different pathways, but the net effect is for there to be a protection against cell death, to be proliferation, to secrete all sorts of cytokines, and to secrete antibodies, which will then fight the infection. So it's an activation signal. And it's a transient activation signal because once the antigen or once the B cells proliferate and the antigen is eliminated or reduced, the signaling stops. In conditions, in many types of lymphomas and in Waldenstrom's, what happens is this signal that's propagated through this tyrosine kinase here called BTK, there's actually mutation in this molecule or in the complex of proteins that forms this signaling molecule. So MYD88 actually binds to this and it results in constitutive activation. So this BTK molecule now is continually signaling and telling the B cell to proliferate, not to die, to secrete antibodies, and to expand. And it doesn't shut off. And that's why one ends up with other mutations developing because there's continued DNA synthesis, and that's why you end up with the lymphoma. Now, the BTK inhibitors do exactly that. They come in here, they bind to this BTK molecule, and they turn it off. And it's a very specific effect. And it's an effect that is unique to the B cell. This BTK is not present in many other signaling pathways. And therefore, the toxicity profile is somewhat confined, is not like chemotherapy where many different types of cells and tissues are adversely affected, but it's really limited to a very small number of cells that do express this BTK molecule. Now, it's, and so what happens when you use this ibrutinib in Waldenstrom's? This is, I know you all know Stephen Treon, who is one of the leaders in this field, and he was one of the first to study ibrutinib in Waldenstrom's. And this is a small initial trial in treatment-naive patients who are symptomatic. So this is the same type of population that we're talking about here. Of 30 patients, all 30 patients responded. There was a 100% response rate, irregardless of what your mutational status was. So that's good. The only thing that's not quite perfect here is that most of the responses are not what we call deep responses. Most of the responses are partial responses and minor responses. When you add them up, the entire major response rate is 83%, but there aren't, in this study, there were no complete responses, disappearance of the paraprotein and disappearance of the clone, at least, that could be detected. And there is very few very good partial responses, only 20%. It's a little higher if you have the MID mutation and CXCR4 wild type, and it's lower if you actually have a mutation of this other molecule. So these, again, are prognostic populations of slightly different types of patients here. But so we have a molecule, a treatment, a small molecule, targeted therapy that can help most patients, but they're not what we would call deep responses. And this is an example of what happens with patients. This shows the response rate over time. And this shows the patients who are mutant with respect to MYD88. They have higher response rate than those who are mutant and mutant with CXCR4. But the point is, you can see that with time, the complete response rate is higher, and it's higher for the MYD88 mutant and the CXCR4 patients who are wild type. And this is the overall response rate. Now, when we talk about more deeper responses, again, they're not quite as high. This doesn't include the very good partial responses. This is just partial responses. And again, they're better in patients who have wild type CXCR4. In patients with Waldenstrom's, you expect the IgM to go down, and you can see it continues to go down. It goes down deeper if you have the wild type CXCR4, and you can expect the hemoglobins to come up. Many patients are anemic when they start, and their hemoglobin levels go into normal values, and that's what we consider valuable responses, even if it's not what we call a complete response. And the toxicity profile with this type of treatment is quite favorable. I mean, because these are not cytotoxic, these are not chemotherapy drugs, these are targeted drugs, they're more specific for the B cell pathway. And if you look at, for example, what we call grade 3 toxicities, more severe toxicities, this is the percent. The percent is very small. And it's interesting that the higher numbers here that you see are, for example, hypertension. We have atrial fibrillation at only 3% here. Actually at only 10% in grade 2 level. And there are some events of bruising that you see, which again are lower grade. So it's it is a treatment that causes responses and helps patients with respect to their clinical symptoms, and it is very well tolerated for the most part. There are a few of these events of special interest that we see, but they're not very severe for the most part. So that's why Ibrutinib is a very important drug. Now, most recently, there's been another trial, a variation on this theme called the Innovate Trial. And I'm showing you this because this has been approved by Health Canada, although this combination is not funded. And it's a trial which combined Ibrutinib and Rituxan being the monoclonal antibody, and compared it to Rituxan alone. It included both treatment naive and previously treated patients. There were 150 patients. It was a randomized trial. You can see that when you look at the two different arms, half of the patients in each arm were, approximately half were treatment naive patients. And this shows the response rate for the Ibrutinib and Rituxan compared to Rituxan. Now, it's not really a very good comparison because I would say most places around the world would not use Rituximab alone as a comparator or as a treatment. So yes, we have a treatment, a combination that's better than Rituximab, but this is not a standard treatment. But nevertheless, there is a pretty high response rate. You are seeing a few complete responses here, and you're seeing some very good partial responses. So what's a very good partial response? I think I have a slide that shows that, but a very good partial response is the M protein decreasing by 90%. And a partial response is only decreasing by 50%. And then complete response is decreasing by 90% and a loss of the protein completely, and also no detectable disease in the bone marrow. And this is the progression-free survival curves for Ibrutinib and Rituximab versus Rituximab. Of course, this is better. And it worked equally for whether you were treatment naive or whether you had previous treatment. And it's too early to say anything about survival because it's only going out for 3 years, and we know that expected life expectancy for patients with Waldenstrom's is longer than that. The adverse events, there were, when you add Rituxan to a treatment, you do get infusion-related reactions, which you see here. This was not present with just Ibrutinib alone, and of course you see it in both arms. You do still see some of the hypertension and atrial fibrillation, which you don't see in these patients who didn't get Ibrutinib. So these events of special interest, are still part of this a toxicity profile of this treatment combination. They don't go away, and now you add the combination. You add the infusion reactions, which really are only present during the first infusion. It's hard to know whether Ibrutinib and Rituxan is better than Ibrutinib, but it's definitely better than Rituxan. So the use of Ibrutinib and Rituxan results in significantly higher rates of progression-free survival than Rituxan, and you see these atrial fibrillation and hypertension. So that leads us to Calquence, or acalabrutinib. And acalabrutinib is a second-generation BTK inhibitor, and it's supposed to have its advantages over Ibrutinib. And I thought I would show these two bits of scientific data, and I think seeing is believing, so I think you can understand just by the visuals here. These are called kinase blots, and these tyrosine kinase blots show what tyrosine kinases. So tyrosine kinases are families of these signaling molecules, and every tissue has their own types of tyrosine kinases. And B cells have Bruton's tyrosine kinase, but there's literally hundreds of tyrosine kinases in the body. And if you look at the binding of Ibrutinib to these different tyrosine kinases, you can see probably as many as 50 different kinases that are bound to by Ibrutinib. And there's only a handful that acalabrutinib binds to. And the level of binding, you only need a very small amount of Ibrutinib to actually result in 50% inhibition of the enzyme. This is IC50. So very small amounts of, and so this is what you would want for BTK, just a very small amount of this this molecule being able to inhibit it, but it's also inhibiting all of these other signaling pathways. And that's probably where some of these toxicities come from. The cardiac toxicity, the hypertension, the atrial fibrillation is related to the fact that this ibrutinib is binding to other tyrosine kinases. Acalabrutinib doesn't bind to these. And if it binds to it, it binds at 1,000 times lower affinity. So it's much more selective for B cells and Bruton's tyrosine kinase, and you would expect it to have a better toxicity profile. Now, it also has a very short half-life, and acalabrutinib is given twice a day. It must be given twice a day, whereas ibrutinib is given once a day. And when you give a molecule twice a day, you end up with kinetics in the pharmacokinetics in the blood where you don't get as high peaks and you don't get as low troughs. The level of the drug stays within a very tight window. And this is different for ibrutinib, where you give it a higher amount once a day, every 24 hours, it goes to a higher level, and those higher levels can result in toxicities. And then it actually goes down to a lower level beyond this therapeutic window, before the next dose is given. So with acalabrutinib, there's almost complete binding after a few days of the BTK molecule. So these are considered advantages. Is there a question, or is it just no? Okay. So that's theoretically why acalabrutinib might be a better BTK inhibitor than ibrutinib. Now, Calquence has already been studied in several other malignancies, CLL, mantle cell lymphoma. I've just picked out some bits of data, but it is approved for first line for relapsed and refractory CLL, for frontline CLL, based upon some data from these studies here, where you can see the acalabrutinib arm is doing much better than the control arm. So this is these are pretty dramatic results. And again, relapsed and refractory mantle cell lymphoma is another disease where there's activity of acalabrutinib in that disease. Now, has acalabrutinib been studied in Waldenstrom's? And the answer is yes. It has been studied in Waldenstrom's in a single-arm, multi-center phase 2 trial. 122 patients were considered for this trial, but only 76 patients ended up receiving the treatment for various or being considered evaluable. Of these, most of these patients had previously treated Waldenstrom's, although there were 7 patients who had first-line treatment. And these are the response rates for the treatment naive and for the refractory treatment, using different ways of judging response. But the point is that, again, a very high response rate. Most of the patients have partial response. There are some very good partial responses in the patients with relapsed. When you look at the MYD88 mutated group and the CR or the MYD mutated group as opposed to the wild type, you see even more of, and most patients do, of course, have MYD88, you see more of these very good partial response. So this could be an indicator that you are getting a little bit deeper responses, more very good partial responses, which we didn't see very much of in with ibrutinib. And then these are the outcomes. Now the follow-up is, these are relatively new trials. The follow-up is not that long. This is looking at the treatment naive versus the relapse, but there's basically no difference, and you're seeing very favorable durations of response with and progression-free survival and overall survival, with patients, most patients staying in remission at least as long as these patients have now been followed. So this is all very promising, but what it does most of all is it shows that this treatment is active, that this drug is active in Waldenstrom, just like ibrutinib is active. I show this slide because this just makes this point, looking at a number of different treatments, most of them treatment naive, although there is one for recurrent, treatments for first-line patients with Waldenstrom's. And you can see that there are different numbers of patients in these trials. This is the biggest trial, and probably we should pay most attention to this trial. And these are different treatments: Ibrutinib, Acalabrutinib, bendamustine, Rituxan. Some of the trials I've shown you already. But the point I'm trying to make here is the complete response rate is quite low. And except for this outlier trial, which didn't use a standard set of response criteria to judge response, except for this trial, which is an outlier, even the very good partial response. So again, very good partial response is a greater than 90% reduction in the M protein. Most patients did not have a 90% reduction in their M protein. In fact, they're closer to very low responses. And we've actually looked at this data carefully. We've done what's called a meta-analysis, and the complete and very good partial response rate, if you take into account all of these trials pretty well, is about 23%. So complete and very good partial response rate. What that tells me is that there's a lot of room for improvement. There's a lot of room where we can get this complete and very good partial response rate up to the rates that we see in other types of lymphomas. I mentioned that the complete response rate for CHOP, for diffuse large B-cell lymphoma, is 70%, and it's even higher if we look at some other combinations. So that's the introduction I want to provide you, and it provides the rationale for the BRAWM trial. And the BRAWM trial is the new trial that we're about to open here, which I'm the principal investigator of. It's a multi-center trial. BRAWM stands for bendamustine, Rituxan, and Acalabrutinib in Waldenstrom's macroglobulinemia. And it's a phase 2 trial of these drugs, so the bendamustine, Rituxan, and the second generation BTK inhibitor. So this is the more selective. And I didn't mention to you that in those studies with Acalabrutinib and Waldenstrom's, there were no cases of atrial fibrillation or hypertension or arrhythmias. And they were smaller trials, so it doesn't mean that there are none, but it means that it seems like it might be more favorable than was seen with Ibrutinib in untreated Waldenstrom's macroglobulinemia. So the hypothesis here is that combination therapy with 2 active therapies for Waldenstrom's macroglobulinemia. So I told you that our standard treatment is bendamustine, and I'd say across Canada, that's a standard treatment, bendamustine and Rituximab. And if you combine that with the second generation BTK inhibitor, Acalabrutinib, which is an up-and-coming treatment, and in some places might even very soon become a first-line treatment, certainly can be a second-line treatment, that this combination of these 3 drugs will result in synergy that will produce deeper and more durable objective responses than either treatment alone. And whereas bendamustine Rituxan or Acalabrutinib alone, if you're being generous, would be expected to produce an average combined CR and VGR PR rate of 23%, which is identical to that seen with Ibrutinib and Rituximab. We expect the combination to produce higher rates of CRs and VGPRs. And in this trial, and so we've designed this trial so that if we look at the response rate that we detect, and we look at the confidence interval around the range of what it could be for the sample size, the lower level of our confidence level is designed to be greater than 23% if we achieve a complete and partial response rate of over 45%. And this will be associated with higher rates of MRD, which we haven't even talked about, but longer than expected progression-free survival. So we're trying to develop a stronger and deeper treatment that will keep people in remission longer with this condition. So I just want to, you might say, well, what's the toxicity going to be like if we combine all those 3 drugs? We know that the bendamustine and Rituxan has certain toxicities. We know that Acalabrutinib may have certain toxicities. What can we expect? Well, this combination, bendamustine and Rituxan and Ibrutinib, so it's not Acalabrutinib, but Ibrutinib, has been tested in small lymphocytic lymphoma. It was actually a randomized trial where they compared it to bendamustine Rituxan. And first of all, what you can see is there's a dramatic improvement in CLL when you combine all three drugs. And ibrutinib is active in CLL, and bendamustine rituximab is a line of treatment for CLL. So it's very encouraging that you are seeing a much greater PFS than bendamustine rituximab. But this is a complicated slide, and it's looking at the toxicities for the 3 drugs versus the 2 drugs. It's looking at grade 1 and grade 2, grade 3. And the bottom line here is, and you really can't, it's hard for you to see each one of these, but if you look at grade 3 neutropenia, it's 18%. In bendamustine rituximab, it's 18% in the 3-drug combination. There's some diarrhea that occurs in 2% of patients, 1% of patients with the. So the bottom line is there were no new unexpected safety signals. This is a quote from the discussion in the paper, and thus these results indicate that ibrutinib can be safely combined with bendamustine rituximab without cumulative toxicities. And that's what you might expect, that there wouldn't be exaggerated toxicities because these are drugs that have different toxicity profiles. So with that rationale and with that sort of a little bit of a background why we think this will be safe, the objectives of this trial are to document the complete response rate and also the very good partial response rate of patients treated with bendamustine rituximab and acalabrutinib in patients with Waldenstrom's macroglobulinemia. Now this slide is wrong. Somehow this old slide got in here. It does not include marginal zone lymphoma. And we are trying to document the rates of overall objective response, VGPR and PR. We will be documenting MRD rates, PFS and OS, and the safety profile. And this is the slide I meant to show. So that slide wasn't removed. But so this shows you the CR and VGPR rate of first-line treatment with bendamustine rituximab plus acalabrutinib in patients with Waldenstrom's using response criteria from the 6th International Workshop as assessed at cycles 7, 12, and 18. And then the secondary objectives are, as I mentioned. It's a single-arm trial. All patients will get this treatment. And the reason why I went over that little bit of a background in terms of what the CR and VGPR would be expected is we will be comparing to historical controls of patients who had who had the individual treatments, either bendamustine rituximab or acalabrutinib or ibrutinib as first-line treatment. These are the criteria that we use to judge response. Again, VGPR, a 90% reduction. And these are the inclusion criteria in the study. So a patient will need to have biopsy-proven Waldenstrom's macroglobulinemia, will not have received any previous systemic treatment for this disease. In rare situations, sometimes plasmapheresis is required if patients have symptomatic hyperviscosity, and that's acceptable because that's not really a systemic therapy. That's a stopgap measure to control condition initially, or even corticosteroids will be allowed initially. They'll have to be able to provide written consent. And they'll have to have one site of measurable disease. Now, the measurable disease could either be a lymph node that's enlarged, that can be by imaging, and we see that in patients, or it can be an elevated IgM paraprotein. And you really need, all patients with Waldenstrom's pretty well have an IgM paraprotein. That's part of the diagnostic criteria. So this criteria will be easy to meet. They need to have symptomatic or impending symptomatic disease or evidence of hematologic or biochemical compromise, because I know many of you, or some of you, or you may know people who have Waldenstrom's who are being observed in clinic without treatment because they are not symptomatic and they do not have hematologic or biochemical compromise. We cannot put people on the trial unless they have symptomatic or impending symptomatic disease. They must have a pathology sample must be available. So patients will need to have a bone marrow prior to starting treatment. And this will be sent for molecular testing. So we will be doing special molecular testing on all patients at the diagnosis for MYD88, for CXCR4, and also for P53, because P53 is another marker which predicts a more difficult type of course. And patients will have to have a good performance status. And they have to, these are the standard criteria that are present in most trials. I'm not going to go through these. Exclusion criteria, if they've had previous systemic therapy for Waldenstrom's, they're excluded. If they're on some other type of trial, they would be excluded. If they're considering autologous stem cell transplant after this treatment, they would be excluded. If they're on warfarin, they would be excluded because BTK inhibitors cannot be given with warfarin, but if the patient is on warfarin, it can be changed to a direct-acting anticoagulant or a low molecular weight heparin or some other type of anticoagulation. If they have symptomatic atrial fibrillation that can't be controlled or hypertension, these would be relative contraindications, but most of the time we are able to control these conditions. We would have a cardiologist help us with that. And this is the design of the trial. The trial is shown here. These are at the top here are the cycles, cycle 1, cycle 2, cycle 3. So these are 28-day cycles. And then it jumps to cycle 7 and 3 months apart, and then long-term follow-up every 6 months. For the first 6 months, patients will get bendamustine monthly. It's actually given 2 days, day 1 and day 2 every month intravenously. Rituximab is given 1 day every month, either sub-Q or intravenously. And then acalabrutinib is given every day by mouth, twice a day, and it's for 12 months. With ibrutinib, often ibrutinib is given indefinitely until progression. With this treatment, with this trial, we are going to stop it after 12 months. We feel that there'll be sufficient enough reduction in the lymphoma that it will be safe, that we will induce deep responses, and it will be safe to be able to stop the acalabrutinib at this time point. There will be standard labs to monitor overall status and the status of the Waldenstroms with IgMs and other things every month. Bone marrow will need to be done at the beginning, and it will be done for mutations, as I mentioned, but also for these MRD assessments. And we've indicated that there will actually be 4 bone marrows throughout the 18 months of this treatment. That's something that many might not like. The idea here is to document using a test that's 100,000 times more sensitive than standard morphologic tests. So we're actually going to be sequencing the DNA in the bone marrow at all these different time points to look for evidence of the Waldenstrom's immunoglobulin molecule. So it's a very sensitive test, and that will be consistent with the hypothesis. There'll be CT scans done to document any lymphadenopathy. We'll be looking at adverse events and evaluating this response at these different time points. So this is the design of the trial. Oops, I'll go over here. We will be doing some translational studies on samples that we take from either the blood and the bone marrow, and I've already really mentioned these. Next generation sequencing will be used. This is going to be done at a lab outside of Toronto, actually in Sudbury, which has a next generation sequencing facility. And we will be measuring these genes that I mentioned. And the MRD will be done by one of the leading biotech companies in the US that does MRD assessments, again, by next generation sequencing. And they've established a collaboration with us so that they will be doing this as part of a research collaboration as opposed to a fee for service, which we are very pleased to have been able to have arranged with them.
Neil,
yes.
Somebody was asking, what is MRD stand for?
Minimal residual disease. So it's basically a very sensitive way of looking for evidence of the Waldenstroms in the body, in the blood, or the bone marrow. So it's by molecular sequencing. I don't think I need to go through these statistical considerations. I've already mentioned the rationale that we're trying to establish a treatment that's significantly better than either of these treatments alone. And there will be one interim analysis after 10 subjects have completed at least 1 month of therapy with a DSMB, which will review the data to ensure that there are no safety signals and that we should go on with the trial. So this is one of the last slides I have here. This is where we are with this trial. So the protocol, as I mentioned, has been written. We've had experts. We've had the Dana-Farber group, Dr. Castillo and Trion, who's helped us with some of the design aspects of this. We've had several different reviews now. Acalabrutinib comes from the company AstraZeneca, the same company that's hopefully going to have their COVID vaccine approved in Canada pretty shortly. And so they're the funder of this, and they are providing the drug, acalabrutinib. It's been approved by Health Canada, so we've got a very rapid approval by Health Canada. It's been approved by the Ontario Provincial Ethics Board. We've established collaborations with, as I said, Adaptive Biotechnology, who will be doing the next generation sequencing. We've established a collaboration with Dr. McClure, Health Sciences North Genomic Laboratory for the mutation analysis. All of the trial documents have been completed, including the database and CRFs and things like that. We have recruited 11 sites across Canada who have said that they will participate. They're in various states of evaluating the protocol, signing research agreements and agreeing or approving their site budget. Odette Sunnybrook is the lead site, and it's already gone through all of these steps. The contract is approved. We've had what's called the site initiation visit, and there's just a few steps left to complete, which we've been working on this week to be up and running at the Odette as the first site. And then over the next, I would say next 3 months, these other sites will come aboard in different parts of Canada. So what I've shown you is that Waldenstrom's is an uncommon non-Hodgkin's lymphoma subtype with many unique features. It's a prototype of a cancer with an almost universal actionable driver, a genetic mutation, and that mutation allows us to use these targeted drugs. There are many therapeutic options with cytotoxics, monoclonal antibodies, targeted drugs, and the treatment algorithm is evolving. And it's safe to say that the optimal frontline therapy that is well tolerated and induces long-term remissions still needs to be established. And the Braum trial will test one such well-justified option. And this is the last slide. This is Braum. This is our new logo. It's a Canadian trial. It's all happening in Canada, and it's AstraZeneca Canada that's helping us. And these are the different cancer centers across Canada that will be participating in this study. So I'm going to stop there. I'm happy to have any discussion or questions, so I can turn it over to Paul.
Neil, the first one with that slide up, those are the centers that the 11 centers you were hoping to have on side?
Yes.
One in Saskatchewan, one in Montreal, Manitoba, Alberta, BC Cancer, Halifax, and what's TOH?
That's Ottawa.
Okay.
Tom Baker's Alberta. And HEJ, I don't know what it stands for, but it's Quebec. It's in Quebec. It's another site in Quebec.
Okay. Well, that's wonderful, because one of the questions that we were getting on the chat was where the sites would be. So I think that answers that question. Okay, the first question we have on the chat was, in terms of COVID vaccine, does having a low IgG make a difference in how a patient responds?
Yeah, I mean, actually, I knew that COVID vaccines was going to become an interesting question, and it's a very complicated question. And, it's complicated when you have these lymphomas and different types of B-cell malignancies, because B cells are required to generate immune responses. And, with many of these lymphomas, you do have disorders of these B cells. And yes, it's thought that when you have low immunoglobulins, that can reduce your ability or your recall responses, because what it means is that you don't have the depth of antibodies to recognize as many different determinants. Now, with that said and done, new responses should be able to be generated. But it has been shown that, for example, with CLL, patients with CLL, just by having CLL alone, do not make good antibody responses. And the other unfortunate thing is that it's been shown that with Ibrutinib, that impairs your ability to make antibody responses. Because as I told you, Ibrutinib shuts off the ability of B cells to be activated. And Ibrutinib basically will reduce the responsiveness of B cells to a flu vaccine. And it will also reduce it hasn't been studied yet with COVID, but there's no reason why it wouldn't also reduce it to COVID vaccine. Now, with that said and done, Rituxan also does the same thing. And so if your standard treatment for Waldenstrom's was bendamustine and Rituxan, you will not make a good immune response to flu, that's been shown, for 6 months after you stop Rituxan. In fact, I tell my patients not to get flu shots when they're on Rituxan. And the data with Ibrutinib is just more recent, and it also impairs. Now, and actually, it may be that one way around. It's also been shown that older people don't make as good an immune response. So, and that's why when you get your seasonal flu vaccine, there is a double dose or a high dose flu vaccine that can be used in older people. And what I'm hoping is that that type of vaccine for COVID might become available for older people, but also for people with these types of malignancies where their immune response is impaired. And we've even sent a letter to AstraZeneca, who does make COVID vaccines, to inquire about what they think about this. And so the answer is it will be problematic if you are on this trial, but if you're on any treatment for Waldenstrom's, you will also have an impaired immune response and not make a good antibody response. The secret would be to have vaccination before you go on a trial, or before you get a Rituxan, or before you get Ibrutinib or acalabrutinib. Once you have the immune response, it's there. Those drugs won't affect it. It's just you won't be able to generate new immune responses.
Thank you. There's a question. At some point, they factor B cell symptoms into prognosis. Does it still?
In many types of lymphomas, the answer is yes. So Hodgkin's disease, yes, you have stages A and B, and the same with diffuse large, same with non-Hodgkin's lymphoma, but not for Waldenstrom's. The staging for Waldenstrom's does not include or the prognostication does not include B symptoms. Actually, one of the most, believe it or not, one of the most important factors, prognostic factors, which has even gotten extra emphasis, is age. And so, for example, in the new revised staging criteria for Waldenstrom's, if you're over 75, you get 3 points for that rather than just 1 point. And but B symptoms are not included in the staging or prognostication.
Thank you. Why is Ibrutinib not a preferred regimen?
I think that that's a good question, and I thought that you might ask us that, or ask me that. I think that there's a couple reasons. One is that the trials aren't as mature as, let's say, with bendamustine Rituxan. So patients who've been treated with bendamustine Rituxan have been followed for 10 years, and we know that they have responses that on average last 5 to 6 years. Now with Ibrutinib, the follow-up is more like 3 or 4 years. We don't have that, and yes, it looks very promising, but we don't know what the PFS, or the progression-free survival curves, are going to look like, at 5 years, at 6 years, at 7 years, at 8 years. And therefore, it can't at this point be considered a preferred treatment. And it's an expensive treatment, which is if you can achieve similar results with a less expensive treatment, that you might consider the less expensive treatment to be preferred. Another reason why, and I've been involved in discussions, even physician groups discuss this, which is a preferred treatment. Is it a treatment that lasts 6 months or 12 months? and then is stopped and you're off treatment and you go about your normal lifestyle and you're not taking treatments? Or is it something like Ibrutinib where you're on it indefinitely, 3 years, 4 years, whatever, every day, taking a tablet? And so there's a number of reasons why it may not be considered a preferred treatment. And again, it's a good treatment. It's a targeted therapy, which is the way we want to go. I believe that if you look at our history of what's happened for cancer treatments in general, we start off with one drug that's active, and we figure out how can we get even more mileage out of this by combining it. If you look at CHOP, which is used for, or ABVD, which is used for Hodgkin's disease, which cures 85% of people with Hodgkin's disease. So Hodgkin's is a lymphoma we can cure 85% with chemotherapy. 4 drugs combined. So right now we're at the point with this target therapy where we're talking about one drug. And I've shown you its limitations. It's good. It has a favorable toxicity profile. It can stabilize disease and cause improvement in disease symptoms and cause minor responses, partial responses, but it doesn't cause deep responses. And we're not curing patients. And it's only one drug. So we've got to eventually figure out how can we get the most mileage out of this. Braum Trial is something that is designed to see if we can get more mileage out of acalabrutinib by combining with other drugs, getting a combination treatment that, there's no reason we can't mention cure, but maybe as we develop better combinations, I'm not saying this is the combination, but there's no reason we can't get better results and better treatments like we have in other types of lymphomas.
Thank you. So we know where the various trials or trial sites are. How would somebody, perhaps not in Toronto, I presume in Toronto they would phone you or Sunnybrook to try and get on the trial, but if they were in another center, how would they get, and they were interested in this clinical trial, what do they do?
Yeah, that's great. And thank you for asking that question. And I hope that within 3 months or so, all of these major cancer centers, the hematology departments there will be well aware of this trial and will be, if you're referred there with or if you contact the department, they'll be able to put you in contact with the investigator there or the investigators, maybe several, that will be running this trial. But I have put an email on this slide here. I hope all of you can see it. It's called BRAWM. So we do have an email. This goes to our project manager for this entire trial, who is interacting already with these different sites, and she will help direct you to the appropriate site. You say you're in Alberta, she'll send you the coordinators, the trial coordinator, the principal investigator, emails or contact information at those sites. So write down BRAWM. That will get you to our newly hired project manager, who will be in charge of helping you.
Thank you. That's very helpful. I didn't notice that email at the bottom, so that's perfect. The next question is, I know 95% of us have the MYD88 mutation, but you mentioned wild type and mutation and the mutation of MYD88. Can you touch on the difference?
Well, okay, so there's two, I showed you data on 2 different genes, the MYD88 and the CXCR4. Both of those genes can either be wild type or mutated. 95% of Waldenstroms have a mutation of MYD88. So, and patients who have a mutation of MYD88 respond better to most treatments. They respond better to the BTK inhibitors because it's the exact molecule that the BTK inhibitors are targeting. The other mutation is called CXCR4. Now that's a different gene, and that's a gene that drives a different pathway, and Ibrutinib has no effect on that other pathway. So basically, if you have mutations of both of those genes, you have 2 different powerful pathways driving your Waldenstroms. The Ibrutinib will take care of the MYD mutation, but the CXCR4 mutation will basically produce a progression of the lymphoma that won't be controlled as well with the Ibrutinib alone. So it's basically a bad molecule to have the CXCR4. About 40% of patients will have CXCR4 mutations.
Thank you. There's a question, if you have low IgG, would you recommend IVIG treatments?
Yeah, so now we're using SCIG, so that's subcutaneous IG. That's something that can be self-administered at home. We have criteria for recommending it. Many people with Waldenstrom's and other types of lymphomas, CLL, other types of lymphomas, have low immunoglobulin levels, IgG levels. And we generally recommend replacement therapy with SCIG if you have 2 episodes of infections in a 12-month period that require antibiotics. So if you have bronchitis or sinusitis or tooth infections or whatever, if you have 2 or more of these a year and your immunoglobulins are low, you should be on SCIG. On the other hand, you have people whose levels are low, but they don't get any infections, and we generally don't replace those people. So there are criteria. Now, there's a lot of flexibility in this, and different hematologists will have different policies that they follow. But for the most part, I know at our group, we all pretty well wait, and we wait for some evidence of infections to start. Because once you start the SCIG, it's a pretty permanent therapy. You're going to be taking these injections every week. You're going to be giving it's like an insulin injection, not quite, it's a little different, but you're going to be self-injecting this every week for years. So we want to make sure you really need it before you start it.
Thank you. The next question is, suppose someone has participated in this trial and later on they need further treatment. What treatments would be excluded because of taking this set of drugs?
That's a really good question. We are using many of the first line drugs. We're using up the best first line drugs that you can use for this condition. With that said and done, I have a slide I can show you, but maybe I'll just talk to it. If you have a really good response to your first line treatment, and generally we use if you look at the NCCN, and they say 3 years. I say even longer if you have 4 years or 5 years, which I consider a good response to your first line treatment. There's no reason you can't go back to that treatment again. The exception being with, let's say, Ibrutinib, because Ibrutinib, you'd be on that for the 4 or 5 years and you would eventually progress while on it, in which case you probably wouldn't want to go onto a BTK inhibitor again. With this treatment, if you relapse 5 years after this treatment, it would probably be reasonable to go back to bendamustine Rituxan. It would probably be reasonable to go back to Ibrutinib, even acalabrutinib. And then there are other drugs, which I showed you in that long list. There's Bortezume, there's all sorts of other drugs that can be used. But the bottom line is you can go back to the same drugs if you've had a long initial response.
Great, thank you. Is acalabrutinib approved and available in Canada right now?
Acalabrutinib is approved, but it's not funded, I believe, for any indication. It's recently been approved by Health Canada in CLL. It's not approved in Waldenstrom's.
So Waldenstrom patients right now cannot get acalabrutinib.
They could not get it funded. The drug acalabrutinib is approved, and it could be used if there were some level of funding.
But doesn't it have to be approved for each disease?
Yes, it does have to be approved. So it could be approved for CLL. There is a little bit of flexibility, and I haven't had that situation yet where we've tried to do that, but you know, CLL is a type of indolent lymphoma. Waldenstrom's a type of indolent lymphoma. There are situations where there's compassionate programs. There are different types of programs where, you know, it can't be used in a totally different indication, but there is some flexibility in similar types of indications. So I wouldn't say it. I haven't tried to use acalabrutinib. I know I have had colleagues, even though it's not approved for CLL, it's not funded for CLL, it is approved for CLL. I've seen many, some of my colleagues use acalabrutinib for CLL where they've felt that the toxicity profile of ibrutinib was prohibiting use of ibrutinib, and they have gotten it through compassionate programs. So it's not funded, it's approved for CLL, but they have been able to get it. Whether you could do that for Waldenstrom's, I don't know.
Thank you. Next question is, are there ever delayed responses to treatment, or is it always seen immediately? Also, what's the role of dexamethasone in the treatment?
Yeah, those are good questions. If you look at some of the slides I showed you, the responses seem to occur within, at least they start, but they're pretty significant. I mean, if you remember those bar graphs that I showed you for each month with certain treatments, you already had good responses in 90% of people by 2 months or 3 months. So they do occur generally pretty early, but I have had patients where I was about to give up, and 4 or 5 months into the treatment, we started seeing responses. And then the responses, when I say give up, I mean try a different treatment. And then the responses continued for a long time, even after we stopped the treatment. So everyone's a little different. I'd say in general, the responses occur pretty quickly, but I think that I have seen patients where the responses take a little longer, and they go on even after treatments are stopped. In fact, that's common. I'll see once we've stopped a treatment, the IgMs will be lower each time I see them in clinic for years. Yeah. So.
Thank you. If someone was on ibrutinib and it became too toxic or no longer effective, could acalabrutinib be a subsequent option for them?
Yeah, it's generally felt that you can use acalabrutinib if there's toxicity issues with ibrutinib. If you have progression on ibrutinib, you would not likely get a lot of mileage out of acalabrutinib, and it would probably be difficult to get any type of funding for it. So the answer is, with toxicities, yes. With progression, no.
Okay, thank you. And the last question I have right now is, how does one in Canada get tested for CXCR4?
So actually, it's interesting. When I was organizing this trial, I polled all the different centers in terms of what type of testing do they routinely do. And almost every center in Canada will do MYD88 testing. And I think there was only one center, I don't even remember which center it was, might have been in Alberta, that did CXCR4. No other centers do CXCR4 as part of their standard of care. There are some ways. I mean, there are commercial programs or companies where you can get this done. And the lab in Sudbury, that's how we are getting ours done. They have a panel of sequencing that they do for this gene, and so we've sort of been able to use that. But that's the answer, is that it's hard to get CXCR4. There's only a very few places that can get it. You can get it commercially. Remember Sudbury, if for some reason you want it done outside of the trial, you would contact the lab in Sudbury, and they might be generous and do it for you or for your physician. And but it is being done, of course, as part of our trial. Every patient who's in the trial will get CXCR4 testing.
There's two more questions that have come in, Neil. So what about COVID vaccination for subcutaneous IG patients?
Yeah, well, first of all, I think that anyone who's, if you have Waldenstrom's, if you're not on treatment, if your IGs are normal, if your IGs are low, get the COVID vaccine as soon as you can.
Yep.
It's not, the vaccine will not hurt you. And hopefully you'll get a good enough immune response that you'll be protected. The issues are that in some situations, your immune response, if you're older, if you have low IGs, you may not get a good immune response, but still you'll get some immune response, and it may be that will be sufficient. So, or will help you do better with COVID. So definitely get it.
Okay, and now I think it's the last one. Do you have you suggested a commercial facility that has the CXCR4 test? Where would a layperson go to find a commercial facility?
It's slipping my mind. It's called, I've used it in the past. It's called, if someone sends me an email, I'll find the name. It's,
why don't you and I just stay in contact, Neil, and the next time I put out a newsletter, I'll just put that as a note that you add, and then everybody will have that information.
Yeah, it's an American facility, but we've sent it for, it's often, might be called Foundation One, I'm thinking. Anyway, there is a, I'll find out for sure.
Wow, that's super. Betty, are you still there? I hope. Thank you, that was wonderful, Neil. It was very helpful, very Canadian orientated, and it certainly was, people were very interested, and almost everybody stayed on the whole call, so you didn't drive them away with your technical stuff. So it was very interesting. So just thanks very much from the WMFC.
Well, thank you very much. I enjoyed doing this, and I hope that this will send the message out about this trial. And I'm really excited about this. And the one thing we have to do now that it's all designed and about to start, is we've got to get patients on this and in a timely fashion, so we can, can see if this is truly a better treatment, and then go to the next step. So,
okay, so I'll be in touch with you about that, but I'll also be in touch with you about the sites. And so in our next newsletter, when we send it out to all our WMFC people, we'll put the sites and the BRAWM email so that people can be in touch to try and attract WMers to be on the trial with you.
Great.
Thank you again, Dr. Berinstein. It was wonderful to have you again.
My pleasure. I enjoyed it. Thank you.
And we really appreciate you taking your time. I know you're very busy, and so it's very much appreciated. Just before we sign off, I just want to remind everyone to check the website for your local support group meetings. Check it out. It's a great, you'll love the new website, and